Hey everybody, welcome back to Nutrition Science Assessment and Prescription, Part 2. My name is Dr. Michaela Carlson. I serve as the Director of Research for the American College of Lifestyle Medicine, and my PhD is in nutritional epidemiology, so this is a subject that is near and dear to my heart. The learning objectives for this lecture are to summarize nutrition prescriptions for the most common chronic diseases, including hyperlipidemia, diabetes, hypertension, and cancer, demonstrate an ability to make nutrition prescriptions, describe the role of nutrition in preventing and treating chronic diseases such as cardiovascular disease, describe the role of epigenetics, list at least 3 key epigenetic influencers, and list at least 5 examples of nutrition interventions for diseases. And then we're going to take a deeper look at type 2 diabetes with the second half of our objectives and cite the prevalence of diabetes and prediabetes and the associated cost burden, describe consequences of intensive medication management, describe the pathogenesis of diabetes, the role of nutrition in preventing, treating, and reversing diabetes, summarize key dietary research on the impact of diabetes, describe the diabetes prevention program and its applications, and then list the major physiologic impacts of a plant-based diet in the process of diabetes reversal. So we'll start first with summarize nutrition prescriptions for the most common chronic diseases and demonstrate an ability to make nutrition prescriptions. I think that a key point here to start with right off the bat is that the nutrition prescriptions we're talking about for the prevention and treatment for a variety of conditions are largely the same. Although patients with more advanced disease states typically will need a more focused and intensive nutritional treatment, and we'll revisit again this concept that appropriate dosing, which Dr. John Kelly developed, is a really important concept here. The commonalities across these different prescriptions for disease states are very similar. So we have a foundation diet that's a whole food, plant predominant diet composed of vegetables, greens, and yellow, red vegetables, starchy ones, fruits, legumes, whole grains, and nuts and seeds. It's high in fiber, it's not a calorie-dense diet, it's high in antioxidants, and it's low naturally in saturated fat, total fat, meaning added oils, added sweeteners, and added salt. So there are some sort of disease-specific aspects of this basic foundation diet that are relevant for certain conditions. With hyperlipidemia, the diet component that's sort of most important include decreased meat, increased fruits and vegetables, and replacing trans and saturated fats with unsaturated fats, and then increasing nuts and omega-3 fat intake. For hypertension, we're talking about increasing fruits and vegetables, definitely reducing sodium, and limiting alcohol consumption. For type 2 diabetes, what's relevant is increased high fiber foods and reduced overall fat and reduced refined carbohydrates. And then for cancer, an antioxidant-rich high fiber diet, lower total protein and lower animal protein. But again, all of these components actually are found in the same whole food, plant predominant diet. So even though different aspects of the diet are sort of more relevant for one condition or another, the total diet really kind of encompasses all of this. When making nutrition prescriptions, you want to start by identifying patients for whom a dietary lifestyle approach may yield benefits. And I would suggest you refer to the previous objective, describe practical strategies for assisting patients to achieve dietary changes, or some ideas about how to go about that. But certainly it's advised to apply motivational interviewing techniques in the patient appointment to assess the person's readiness for change and their ability to make changes, their interest, support the patients in self-determination of their own goals, and then help them reformat those goals using the SMART goals format to make the goals more fruitful for them and more concrete and better equip them to follow through with their goals and achieve their goals. And then when possible, provide follow-up resources to encourage adherence to your prescriptions. So ACLM has a lot of resources under our tools and resources page. And we also would suggest, perhaps if possible, email follow-up within the practice or health system, patient support groups, shared medical appointments, either in person or virtually, and referrals to other live events, classes, and other educational experiences that will reinforce the guidelines that you're giving patients. Moving on to describing the role of nutrition in preventing and treating chronic diseases such as cardiovascular disease, it's been known for a long time that the Western diet is very problematic for overall disease prevention and health promotion. And in 1976, there was a seminal publication by Dr. Dennis Burkitt on Western diets, and he really identified low fiber consumption as the common theme among populations with these rising rates of non-communicable diseases. So this was one of the earlier points at which this was pinpointed. But of course, there's been a lot published on this. And fast forward to today, the Global Burden of Disease report that was published in 2017 by the Institute for Health Metrics and Evaluation identifies poor diet as being responsible for more deaths globally than tobacco, high blood pressure, or any other health risk. And dietary habits account for 1 in 5 deaths globally, and that's 11 million deaths and 255 million disability-adjusted life years. And the top 3 dietary risk factors are high intake of sodium, low intake of whole grains, and a low intake of fruits, each responsible for millions of deaths and tens of millions of disability-adjusted life years. This is a bar chart from that same report, from the Global Burden of Disease report. And on the left, you see the mortality rate attributable to diet stratified by region and level of the country's economic development. And then on the right, you see the number of deaths broken apart by cardiovascular disease being in red, which is the biggest proportion, and type 2 diabetes, cancer, and other. So as you can see, this is the list of sort of top concerns. And one thing that's important to remember when you're thinking about diet is because the amount of total energy and the volume of food that a person consumes in one day is finite, any kind of change does not only mean a change to that one element, but it means a replacement with something else. So the more whole grains, fruits, and nuts and seeds someone consumes, the more they're going to crowd out some of those other foods that are problematic, like red meat and processed meat and so forth. And the higher the diet is in sodium, the more likely it is that diet contains prepared foods and refined foods, and therefore that's going to be crowding out some of the other foods that we're trying to emphasize. So it's important to think about that in practice. Here, what's being displayed are the mortality rates attributable to these individual elements, but in practice, it's a closed system. So the more healthy foods a patient can incorporate, the more they're going to crowd out these other things. There have been some really positive outcomes that have been documented for chronic diseases using a more plant-based diet. So we've seen delayed conventional treatment of prostate cancer with Dr. Dean Ornish's study, reduced cancer cell growth and improved survival with breast cancer survivors, prevention of diabetes, improvements in blood glucose and medication usage reductions with a plant-based diet. And we'll talk more about diabetes later. Reduced risk of hypertension, cataracts, COPD, chronic kidney disease, and multiple sclerosis among more plant-based eaters, and even remission of Crohn's disease. So some of these are more emerging kind of areas of study, and some of them are very well established with big or more rigorous trials. But the common theme is the more plant-based the diet, the more positive benefits we tend to see. In terms of preventing and treating cardiovascular disease specifically, first of all, it is a leading cause of death in the US and globally. And some of the established risk factors include diet, obesity, smoking, high blood pressure, hypercholesterolemia, family history of cardiovascular disease, kidney disease, and diabetes. But specifically, the dietary risk factors are higher intakes of saturated fat, animal foods, and dietary cholesterol, and I should add low intake of fiber. So we do see, the epidemiology of cardiovascular disease and diet is promising, and that we know that the rates of CVD are extremely low where people are consuming a traditionally plant-based whole food diet. So here are some examples. In Uganda, the diet was based on vegetables, whole grains, and plant protein. The Tarahumara Native Americans of northern Mexico, staple foods were beans and corn. The Papua Highlanders of New Guinea, staple food of sweet potatoes. In rural China, it was rice and vegetables. And in parts of rural Africa, plantains, sweet potatoes, pumpkin, tomatoes, and green leafy vegetables. And of course, we have these very high rates of cardiovascular disease in Western countries that are driven by our high intake of animal foods and saturated fat. Low-density lipoprotein cholesterol, of course, has been used for a long time as a marker of disease, and we know that lower is better. A physiologically normal range is an LDL of about 50 to 70 milligrams per deciliter. And related to this, the American Heart Association and the American College of Cardiology guidelines on lifestyle management to reduce cardiovascular disease do recommend a dietary pattern that achieves no more than 5 to 6% of calories from saturated fat. And it's important to note that this is actually difficult to achieve on a non-vegetarian diet because any intake of trans fat, saturated fat, or cholesterol above 0% energy may increase LDL cholesterol as well as produce a range of other outcomes. Now, some really promising and very exciting examples of disease reversal, or I should say cardiovascular disease regression, using a whole food plant-based diet are that of Dr. Dean Ornish and Dr. Caldwell Esselstyn. So Dr. Dean Ornish ran the Lifestyle Heart Trial. The intervention was a 10% fat, whole food vegetarian diet, along with aerobic exercise, stress management training, smoking cessation, and group psychosocial support. And this did lead to a regression of plaque stenosis and a reduction in cholesterol. This was a really landmark trial. And of course, this was kind of the beginning of this program eventually being reimbursable by Medicare. So when they published a 5-year follow-up study called the Intensive Lifestyle Changes for Reversal of Coronary Artery Disease, they saw continued regression of plaque stenosis in the intervention group. At 1 year, the average percent diameter stenosis at baseline had decreased 1.75%, but that actually continued to improve at 5 years, and it had decreased by 3.1%, whereas the control group worsened, and that was a randomized controlled trial. Dr. Caldwell Esselstyn, for a long time, ran his intervention with patients, and his intervention diet was very similar, a little different. It was to eat a whole food plant-based diet, definitely eliminating all oil, added oil. That's actually quite similar to the 10% fat goal in the Lifestyle Heart Trial, and as well as eliminating meat products and increasing fruits, vegetables, whole grains, beans, and legumes. When he first started his program, he did allow a bit of dairy and since later discontinued that. So he published in 2014 sort of a sampling of his patients, and it was a case series of 198 consecutive patients, and found that there was a recurrence rate of 0.6% from major cardiac events among adherent patients and 62% among the 21 non-adherent patients. So really impressive. Advanced cardiac disease is typically considered, as you know, not something that can be recovered from. And Dr. Esselstyn's patients ended up living for a long time, typically after his intervention. So it's very promising and really speaks to the potential power of a lifestyle medicine approach. So just listing at least 5 examples of nutrition interventions for diseases. In research, there has been a lot published on the Mediterranean diet. The Lion Heart Study is one major study that you've probably heard of, as well as the dietary approaches to stop hypertension, the DASH diet. So this was a diet designed to improve hypertension outcomes. And both of these, the Mediterranean diet and the DASH diet, are omnivorous diets, but they emphasize whole foods, avoiding refined foods, reducing meat, reducing added salt, and certainly reducing added sweeteners. And there's a lot to show that these diets do have positive benefits. But then, the more intensive intervention really is a whole food plant-based diet. And the Ornish program and the Esselstyn diet are both versions of this whole food plant-based diet. So that's sort of the direction that we're focusing on in this section. Now, describing the role of epigenetics. First, some terminology basics, epigenetic basics. Epi means near, upon, or at, and genetics are hereditary material. So epigenetics is the study of the non-DNA sequence components of genetic inheritance. These non-DNA sequence components act like gene switches that modify and control gene expression through a variety of pathways, and that includes DNA methylation, microRNA, histone acetylation, and there are a growing number of other molecular changes. So a key take-home message here for patients that Dr. Kelly really likes to impart is that your genes are not your destiny. Your lifestyle is your destiny. The changes you make today will change your lifestyle and ultimately change your future. So some of the mechanisms listed in this schematic are, development, environment, meaning in utero or during childhood, environmental chemicals, drugs and pharmaceuticals ingested, aging, and diet. These are all things that can affect epigenetic outcomes. And of course, you can't control what happened in your childhood or necessarily even what environmental chemicals you're exposed to. But you can't control getting older. But diet is a big area where people do have a lot of control over what they take in and what happens to them. And so there are a lot of outcomes associated with these changes for cancer, autoimmune disease, mental disorders, and diabetes. And it's really a message of hope and empowerment for patients that they can take their health into their own hands. We don't know everything about this. There's a lot here still to be studied, but we do know that lifestyle changes actually produce outcomes that have larger implications in a way than what was previously thought. So in one exciting example of epigenetic research, Ornish and his colleagues in another study on prostate cancer did find that intensive nutrition and lifestyle changes altered the expression of more than 500 genes. So it downregulated 453 genes and upregulated 48. And each of these genes played critical roles in tumorigenesis of prostate cancer. So it's just a great example of sort of the cascade of events and the multitude of different outcomes and aids that the body's able to deliver when you start giving it healthy dietary inputs and healthy lifestyle behaviors. Now, listing three key epigenetic influencers. As we've discussed, diet. Another example here is among rat fetus models, high-fat diet alters gene expression in the developing rat fetuses and results in anatomic changes in their brains. Exercise is a big epigenetic influencer. We know that physical activity alters gene expression, just for example, of the GLUT4 receptor, and it does improve glucose uptake, which is relevant for type 2 diabetes. Sleep and sleep deprivation, as well as healthy sleep, alter gene expression, and so does obesity. So again, these are areas where patients really have an opportunity to make a difference in their own lives with their choices, and those choices can have lasting effects. All right, so we're going to now transition and take a deeper dive into type 2 diabetes and diet. This is an area that is really central to ACLM's focus. And first, citing the prevalence and associated cost burden. The prevalence globally we've gone from 108 million cases in 1980 to 422 million by 2014. That's expected to rise another 50% by 2040, and it's the sixth leading cause of death worldwide, 2 million deaths per year. And we have significant increases in all regions of the world expected over the next few years. In the US, the prevalence based on 2017 data we have 34.2 million people with type 2 diabetes, 26.9 of those are diagnosed, with a substantial portion undiagnosed. We also have 1.4 million with type 1, and type 2 diabetes is projected to rise to about 2/5 of the US population in 2060, so it's a huge problem and it's a growing problem. The prevalence by age, race, and ethnicity, stratified here, we have the breakdown for Native Americans, Blacks, non-Hispanic, Hispanic, Asian, and white. The non-white groups do all consistently have higher rates of diabetes, and this prevalence is set to increase across all race, sex groups. So type 2 diabetes is not only a problem because of the negative sequelae associated with the illness itself and also the cost, but as well, the treatment of intensive medication management can even have adverse effects. So we have seen adverse outcomes associated with intensive or increased insulin dosing. And there was an intensive medication intervention trial called the Accord study. It was completed in 2008, and the aim was to aggressively lower blood glucose into tightly controlled levels with medication. And the results are that they did see harm produced in high-risk patients with type 2 diabetes following these high levels of insulin dosing. So increased insulin dosing also is associated with an increased risk of cancer, cardiovascular disease, and weight gain. So there are a lot of reasons besides quality of life and happiness, there are a lot of health reasons to look at how we can stop and reverse that disease without using medication. Now we're going to just go into some of the mechanisms of the pathogenesis of diabetes here. So first, the key metabolic dysfunction is insulin resistance. It's a normal physiologic response to chronic calorie excess. And the most efficient storage form for our calorie excess is adipose tissue. But this energy storage has limits, and exceeding those limits leads to toxicity. And so this lipotoxicity occurs when excess energy is pushed into cell storage. And excess calorie consumption just comes from any calorie consumption that's beyond biologic need, but it does produce inflammation. And of course, one marker of this is high sensitivity C-reactive protein. The insulin resistance is the result of a pushback against this excess energy. So the insulin resistance elevates insulin levels, it exacerbates inflammation, and the continued insulin resistance and lipotoxicity actually impair insulin production. Serum glucose then rises, and the result is impaired glucose tolerance in type 2 diabetes. And the whole thing can happen very quickly, but it usually occurs over years of gradual weight gain and years of unhealthy eating habits. When we look at reversing the pathophysiology of insulin resistance, one way to do this is with severe energy restriction or very low calorie diets. And we're going to talk about a few different versions of that coming up. But it leads to a host of reactions that do end up improving insulin sensitivity, reducing intracellular lipotoxicity and glucotoxicity, reducing triglycerides in the liver and the pancreas and in the tissue. So focusing on reversing insulin resistance, the tissue damage from insulin resistance and lipotoxicity initially are reversible, but it can become permanent. And so changing this excess calorie consumption is really key in reversing this pathophysiology. It reverses the condition and the symptoms. So insulin resistance, impaired glucose tolerance, and type 2 diabetes, they're not the cause, but they're just symptoms. So you have to address not only these symptoms, but really focus on insulin resistance reversal. And a couple other things to remember, insulin it is a hunger driver. It can stimulate appetite and it promotes growth, as in obesity and cancer. And insulin resistance and hyperinsulinemia create a positive feedback loop. So it does accelerate a process with increased calorie consumption, and it's controlling it with insulin or these exogenous insulin or secretagogues. It does worsen the disease. So hyperglycemia and hyperinsulinemia are two symptoms as well of insulin resistance. Non-alcoholic fatty liver disease, Alzheimer's, polycystic ovary syndrome, cancer, and other conditions are also affected by insulin resistance. And so it's a big problem, not just for diabetes, but for a host of other things. And optimal health and function are really just not possible with the presence of insulin resistance and inflammation. So we're looking at removing the cause, which is the excess calorie consumption. So for a long time, historically, type 2 diabetes was thought of as incurable, but the landmark UK prospective diabetes study really kind of established this dogma that it is progressive and irreversible, but with no lifestyle change. So that's important for us, which we'll talk about coming up. Now, when we look at the role of nutrition in preventing, treating, and reversing diabetes, first of all, let's take a look at the definition of remission. This was published in Diabetes Care in 2019. And the accepted level of complete remission is normal blood glucose, so less than 5.7, and for at least 1 year, and also no active pharmacology or procedures, so no medication. Lifestyle is really a primary driver of the risk for diabetes, and lifestyle-related risk factors include being overweight or obese, having high blood pressure, low levels of HDL cholesterol or high triglycerides, not being physically active, and then the dietary risk factors, which lead to a lot of those intermediate health outcomes, are overconsumption, of course, of total energy, and that is driven by high total fat, red meat and added sugars, and high cholesterol goes right along with those other things. And unfortunately, U.S. diets are perfectly poised to increase our risk. The current consumption patterns are very poor. 63% of the American diet is processed food. high or refined foods, that is high in added fats, oils, sugars, and refined grains. We have 25% from animal foods, including meat, dairy, eggs, fish, and seafood. And those are calorie-dense foods. It's very easy to overconsume when so much of the food comes from that source. Only 12% is from plant foods, but half of that is from refined plant foods. So apples and apple pie, almonds and candy, etc. So really only 6% of our diet is from unprocessed vegetables, fruits, legumes, whole grains, nuts, and seeds. And those are the foods that we found that we've seen have the best impact on all these variety of health outcomes. And in the last 100 years, the changes per person per year have included increase from 10 pounds to 140 pounds of sugar, 4 to 70 pounds of oil, cheese increased by 25 pounds. And we've also gotten more sedentary, and television watching has increased, from 0 to 4 hours per day. So our society has gone through a lot of changes with our consumption patterns and our activity level. And, this is, unfortunately, it's exactly the opposite of what we need to be doing. And it's the opposite of what lifestyle medicine practitioners report using to achieve remission outcomes in their patients. So more intensive dietary and lifestyle changes are really essential for remission and reversal. And when we say intensive, we're talking about the adoption of a really substantially whole food, plant-based, low-fat diet. So we're not talking about adding half a cup of blueberries per day to your diet, or one sweet potato a week, or replacing like one serving of white flour with whole wheat flour. We're really talking about a intensive and kind of massive overhaul of the diet. And that's, again, where this concept of appropriate dosing comes in, because to achieve the kinds of outcomes that we're interested in, a big change is really necessary. So how can we do this to reduce calories without losing nutrients? Again, it's a diet that maximizes the intake of whole plant foods. And we're talking about vegetables, fruits, whole grains, beans, peas, lentils, mushrooms, herbs, spices, seeds, and nuts, and minimizing added sugars, animal products, refined grains, and oils. So ACLM does have a position on type 2 diabetes, and our position is that sufficiently intensive lifestyle modifications are capable of producing clinical improvements and or remission in patients with type 2 diabetes, and the optimal treatment to bring about remission includes a whole food plant-based diet coupled with regular exercise, and therefore remission should always be the preferred clinical goal, and lifestyle medicine interventions shown to produce remission should therefore become the standard of care. So that's what we're hoping to encourage all of you to tackle through this. Our position statement was published in 2020 and may be of interest here. And again, this is the concept of therapeutic dosing of lifestyle modifications are necessary, including perhaps a hypocaloric diet. And you can read more about this in the position statement. So intensity of lifestyle interventions really have to be matched to the severity and acuteness of the condition being treated. And the reversal of advanced hyperglycemia requires intensive lifestyle interventions to produce significant weight loss. So we've seen this previously in the Counterpoint, Counterweight, and Direct trials, and they use liquid meal substitutes to achieve significant weight loss. But we have seen among our practitioners that liquid meal substitutes are not necessarily the only way to achieve those same outcomes. The clinical experience is that whole food plant-based diets can also achieve a remission, especially when combined with some intermittent fasting. And the dosing intensity, largely determines the success or failure of the intervention to achieve remission. And I will say that we really need a lot more research here to quantify the effects of the different components of a whole food plant-based diet and the effect on different outcomes and over different time periods, and to compare that with other kinds of diets and interventions. So there's a lot to do, but so far it's very promising. The clinical goal is remission, and medication treatment alone is insufficient to achieve remission. Of course, part of the definition of remission is that no medications are being used, and surgical interventions can do this, but there are a lot of significant risks. It's expensive, and they're also, it's uncomfortable, and there are undesired side effects for the patient. So the weight of evidence does show that a properly dosed lifestyle intervention really can produce remission in a majority of patients. Now we're going to look at summarizing some key dietary research on the impact of diet on diabetes that's previously been done. And again, most of these use a very low-calorie diet or liquid diet substitute. So the evidence of remission for more dramatic changes that are required, we look again to the UK prospective diabetes study, and it actually really proved that diabetes is progressive and irreversible with no lifestyle changes. We know gastric bypass has a success rate because it forces the reduction of caloric intake, and starvation puts diabetes in remission as well. But the Counterpoint study used a very low-calorie diet, and it reversed liver and pancreas triglycerol in just 4 to 8 weeks. Here are some of the dramatic changes seen in the Counterpoint study. You can see from week 0 to week 8, the control group is that small circle right over week 0, and you can see plasma glucose, hepatic glucose production, and hepatic triacylglycerol dropping dramatically, actually just in the first week in the intervention group with the triangles as compared to the control group. So here is sort of the progression in the Counterpoint study. If you look at the controls at baseline over on the upper left, and then the diabetics at baseline, 1 week, 2 weeks, 4 weeks, you can see that they're lacking an insulin secretion response immediately after eating, which you can see in the controls, so between 0 and 20 minutes. And that gradually increases until it looks very similar to the controls at week 4. And then you can also see that the later spike, about an hour after consumption of a meal, is getting higher over the 4 weeks too. And so finally, if you look at the controls again on the lower right-hand corner and compare that to the intervention group after 4 weeks, their curves are looking very similar, very effective. In the look-ahead diabetes trial, one of the objectives was to clarify the remission rate of type 2 diabetes with lifestyle change. So they measured the association of intensive long-term weight loss with diabetes remission, either return to pre-diabetes conditions or normoglycemia. So they had an intensive lifestyle intervention or a diabetes support and education control group. And this was in over 4,500 US adults with overweight and type 2 diabetes. People were randomly assigned to either the intensive lifestyle intervention or the diabetes support and education. So the intensive intervention was quite a few sessions for 6 months, and then follow-up sessions for another 6 months, and then twice monthly contact in years 2 to 4. Or, the education group was just a much more minimal intervention. And their measures were partial or complete remission, defined as transition from meeting diabetes criteria to either prediabetes or non-diabetic glycemia. And the results were that the intensive lifestyle participants lost more weight than the diabetes support and education participants at years 1 and 4, and they also had greater fitness increases at years 1 and 4. The intensive lifestyle intervention group was significantly more likely to experience any remission, either partial or complete, with prevalences of 11.5% during year 1 and 7.3% at year 4, compared to just 2% for the education and support group at both time points. And the intensive group had continuous sustained remission for at least years 2 and 3 and 4 years compared to the control group. So the intensive group did produce a greater likelihood of partial remission of diabetes compared to just the support and education. In the DIRECT trial, the goal was to assess whether intensive weight management within routine primary care would achieve remission of type 2 diabetes. So this was an open label cluster randomized trial at 49 different primary care practices in Scotland, and participants were randomly assigned to either a weight management program or the best practice care by guidelines. And they were stratified for study site and practice size. These were adults with a diagnosis of type 2 diabetes within only the last 6 years. So that's different from the look-ahead trial, which accepted people with diabetes diagnoses which were older than that. And also BMI of overweight or obese, and also not receiving insulin in DIRECT. One important thing I think should be noted here is that the intervention group actually had a total diet replacement of a very low calorie diet formula, just about 850 calories for 3 to 5 months. And their outcomes were weight loss of 15 kilograms or more and remission of diabetes, defined as blood glucose less than 6.5% and off after at least 2 months off all medication from baseline to 12 months. The findings were that at 1 year weight loss of 15 kilograms or more in 24% of the intervention group versus none in the control group, and achieved diabetes remission in 46% of the intervention group versus 4% of the controls. So remission really correlated to the weight loss, and this is very important. You can see that when the results were stratified by the level of weight loss, the rates of remission among those that lost the most weight, which was remember that target was 15 kilograms per more, were much higher. So 86% versus just 57% among those that only lost 10 to 15 kilograms. In sum, there is really good evidence for this need for more dramatic changes that are required to achieve remission. So direct and the very low calorie diet and the weight maintenance diet reversed 46% of type 2 diabetes. With a weight loss of 15 kilograms or more, they reversed actually 86%. And this is, very competitive with gastric bypass outcomes, but without those adverse side effects. And on the look ahead study, the education group only achieved 2% remission, and the intensive group got 12% remission at year 1, but it fell back to 6% at year 4. So actually they concluded that lifestyle doesn't work and you do need gastric bypass surgery, but it really demonstrates that the treatment was just not dramatic enough. It was too mild to achieve the outcome of interest. Here's just a visual depiction comparing the prevalence of remission among these 3 studies, and it varies a lot. And the key take-home message here is that a lot of the variance is really related to the level of intensity of the intervention. So the calorie reduction or the amount of weight loss that the participants were able to achieve. Okay, we want to also spend some time describing the diabetes prevention program and its applications. Just to give an overview, the Centers for Disease Control led this intensive 12-month lifestyle intervention program that was designed to reduce the progression of prediabetes and at-risk groups. So it includes weekly meetings for 6 months, then monthly meetings for 6 months, instructions to meet physical activity guidelines, and focusing on sustainable lifestyle change without gym memberships or intensive physical activity. The dietary advice was to eat less fat and fewer calories and to follow MyPlate, and it does provide virtual or live support. One of the first analyses of this was a randomized controlled trial with over 3,000 individuals with pre-diabetes, and they were divided into 3 groups: a placebo, metformin given twice a day, or the lifestyle modification. And the goals here were 7% weight loss or more, plus 150 minutes of physical activity per week. The outcomes from this program were remarkable, and lifestyle changes and metformin both reduced the incidence of diabetes, but the lifestyle was actually 2 times as effective as the metformin. So this figure shows the cumulative incidence for each of the 3 groups. And, this is very encouraging and is now a very well-known program and implemented in a lot of different settings. Again, the focus here is prevention, and this is not an entirely whole food plant-based approach, but kind of speaks to the ability to make a change with a slightly less intensive approach when the severity of the illness is not quite as severe. So it should be noted that the mean follow-up was 2.8 years, and the study ended early because the interventions were dramatically more effective than the placebo. So for ethical reasons, they had to discontinue that study. But the incident diabetes was 11 for placebo, 7.8 for metformin, and only 4.8 for lifestyle per 100 person years. And lifestyle reduced the incidence by 58%, whereas metformin needs decreased by 31% versus the placebo. And so to prevent 1 case of diabetes during a 3-year span, you need to have only 7 people in the lifestyle program, but 14 people would have to receive metformin. And of course, eating healthier and exercise also has a range of other health benefits that metformin doesn't convey. So some of the lessons learned here are to begin talking with patients about prediabetes and the need to treat it, screen with lab work and questionnaires, discuss the long-term implications, include honest conversations about medical and lifestyle interventions, and discuss all the treatments, including lifestyle treatment, as part of an informed consent for treatments of chronic disease, especially with type 2 diabetes. Discuss opportunities for change, challenges, and sustainability, and focus on the positive aspect of lifestyle. So it's cost effective, there's a comorbid risk reduction, it imparts general well-being and daily health, and then provide success stories and encouragement, and end with follow-up to support healthier choices and minimize fear of follow-up later. Finally, we're just going to list some of the major physiologic impacts of plant-based diets in the process of diabetes reversal. Some of the benefits of whole food plant-based diets are changes in epigenetics and lowering overall risk of chronic disease. So treating chronic disease and maybe even reversing disease depending on the condition. It can normalize angiogenesis, reducing comorbid disease for cancer and heart disease, especially leafy greens, cruciferous vegetables, onions, and mushrooms, lowering total caloric intake and reducing feelings of hunger, so improving satiety following eating. And that can improve weight loss or healthy weight maintenance, improving hemoglobin A1C, and normalizing and sensitization of leptin and epinephrine levels, improving insulin sensitivity, actually independently of weight loss, lowering inflammation, lowering overall endothelial cell injury, oxidative stress, and protecting beta cells through normalizing the lipid profile, and a host of other pathways. Whole food plant-based diets also will improve glycemic control and optimize the microbiome by producing more short-chain fatty acids from the intake of fiber. And short-chain fatty acids are produced by the microbiome. Digestion produces butyrate, and butyrate enhances insulin sensitivity, mineral absorption, it decreases cholesterol and triglycerides, decreases glycolysis in the liver, and it improves satiety. Can be associated with reducing pain associated with peripheral neuropathy, and assists with overcoming food addictions and dependency by changing taste preferences and breaking the cycle of food addiction. Also can lower total cost for healthcare by lowering the need for treatments and medications and interventions. In summary, dietary change is absolutely an integral foundational part of lifestyle medicine care, and a whole food, plant-predominant lifestyle has the greatest potential to prevent disease. With appropriate intensive dosing, a whole food plant-based diet can also serve as the foundation of care to treat existing disease, targeting reversal or remission of chronic conditions. Thank you so much, and congratulations for completing section 5. We hope that you are able to incorporate this information into your practice and enjoy the benefits with your patients that you'll find are achievable with dietary lifestyle interventions.